Welcome to our comprehensive guide on eye surface disorders. In this video, we'll explore several common and important conditions affecting the conjunctiva and sclera, such as pterygium, subconjunctival haemorrhage, flictenular conjunctivitis, xerosis, episcleritis, scleritis, and staphyloma. Understanding these disorders is crucial for recognizing symptoms early and seeking appropriate care. We'll break down each condition, discuss their causes, symptoms, diagnostic clues, and treatment options. Whether you are a medical student, healthcare professional, or simply interested in eye health, this video will provide you with clear, structured information. Let's begin our journey by first understanding what pterygium is and how it affects the eye. Pterygium is a triangular, fibrovascular growth that extends from either the inner or outer corner of the eye, moving horizontally towards the cornea. This abnormal tissue invades and damages the Bowman's membrane, which is a protective layer of the cornea. Pterygium can be alarming due to its appearance, but understanding its structure and progression is key. The part of the pterygium that covers the cornea is known as the head or apex, while the neck and body or base extend into the subconjunctival tissue. This growth can affect vision and the overall health of the eye if left untreated. To better understand pterygium, let's break down its anatomical parts. The portion that extends over the cornea is called the head or apex. This is the most visible and clinically significant part, as it can interfere with vision if it encroaches on the pupillary area. The neck is the narrow segment connecting the head to the body, while the body, or base, extends into the subconjunctival tissue. Knowing these parts helps in assessing the severity and planning treatment, especially when surgical intervention is considered. The exact cause of pterygium remains unclear, but it is commonly seen in people living in hot, dry climates with frequent exposure to wind and dust. These environmental factors are believed to cause chronic irritation and degeneration of the conjunctival tissue, leading to the development of pterygium. It can occur in one or both eyes and is more prevalent in individuals who spend significant time outdoors. Understanding these risk factors is important for prevention and early detection. Pterygium is often symptomless and may be discovered during a routine eye examination. However, some patients, especially those who are observant, might notice a visible growth or disfigurement on the eye. If the pterygium grows large enough to cover the pupillary area, it can impair vision. In extensive cases, it may restrict eye movement, leading to double vision, also known as diplopia. Early recognition of these symptoms can prompt timely medical attention. Clinically, pterygium presents as a red, vascular fold in its early stages due to a rich blood supply. Over time, it becomes white and tendinous. The basal portion is firmly attached to the sclera, while the upper and lower margins are formed by folds of bulbar conjunctiva. On the corneal side, the pterygium extends at the level of Bowman's membrane, destroying it and potentially causing corneal opacities. Recognizing these signs is crucial for diagnosis and management. Pterygium progresses through two main stages, the progressive stage and the atrophic stage. In the progressive stage, the pterygium is thick, fleshy, and highly vascular, sometimes covering the entire pupillary area and significantly affecting vision. In the atrophic stage, the tissue becomes thin, pale, and non-progressive, often requiring no treatment. Identifying the stage is essential for determining the appropriate management strategy. It's important to distinguish pterygium from pseudo-pterygium. Pseudo-pterygium occurs when the bulbar conjunctiva adheres to a marginal corneal ulcer, often due to trauma or inflammation. A key diagnostic test is the probe test. A probe can be easily passed beneath a pseudo-pterygium, but not under a true pterygium. Accurate diagnosis ensures proper management and avoids unnecessary interventions. Treatment depends on the stage and severity of the pterygium. Atrophic pterygium usually requires no intervention. Progressive pterygium, especially if it impairs vision, causes astigmatism, restricts movement, or is cosmetically concerning, may need surgical excision. The procedure involves carefully separating the head from the cornea and dissecting the neck and body from the sclera and conjunctiva. About 3 to 4 millimeters of tissue is excised and the ends are sutured. Care must be taken to avoid injury to the medial rectus muscle. Recurrent pterygium poses a unique challenge and may require advanced surgical techniques. One method is mucous membrane autograft, where a conjunctival graft from the supero-temporal quadrant is used to cover the bare sclera, preventing recurrence. Another technique is Mc-Reynolds' transposition, where the head of the pterygium is repositioned beneath the conjunctiva at the 6 o'clock position and sutured, changing its direction and preventing further encroachment on the cornea. The most significant complication following pterygium excision is recurrence. Despite meticulous surgical technique, the abnormal tissue can regrow, sometimes more aggressively than before. This highlights the importance of careful surgical planning and, when necessary, the use of adjunctive therapies such as grafts to minimize the risk of recurrence and ensure the best possible outcome for the patient. Subconjunctival hemorrhage, also known as ecchymosis, occurs when a conjunctival blood vessel ruptures, leading to bleeding beneath the conjunctiva. This condition is common due to the loose support of conjunctival vessels, especially in the bulbar conjunctiva. Initially, the affected area appears bright red, but over time, the color darkens to a blackish red as the blood is absorbed. Several factors can lead to subconjunctival hemorrhage. Trauma, such as direct injury or head trauma with orbital fractures, is a common cause. Mechanical straining from vomiting, coughing, or lifting heavy weights can also result in vessel rupture. Bleeding disorders, acute conjunctivitis, and even idiopathic causes where no clear reason is found are other contributors. Understanding these causes helps in identifying underlying health issues when this condition is observed. Most cases of subconjunctival hemorrhage resolve on their own within 1 to 3 weeks without leaving any trace. Immediate cold compresses can help stop the bleeding, and antibiotic eye drops may be used if there is direct injury to prevent infection. High-dose vitamin C aids in coagulation, and treating any underlying causes is important. Patients should be reassured that this condition is not serious and will resolve naturally. Flectennular conjunctivitis is a type of allergic conjunctivitis characterized by one or more small yellow nodules on the bulbar conjunctiva or cornea, surrounded by congestion. It is often seen in malnourished children living in unhygienic conditions and is triggered by an allergic reaction to endogenous bacterial proteins, such as those from tuberculosis or septic tonsils. Recognizing this condition is important for prompt treatment and prevention of complications. Patients with flectennular conjunctivitis may experience discomfort, irritation, reflex tearing, itching, and photophobia, especially if the cornea is involved. Clinically, one or more small gray-yellow nodules appear near the limbus, surrounded by conjunctival congestion. The rest of the conjunctiva remains normal. If the cornea is affected, the condition can progress to flectennular keratoconjunctivitis, increasing the risk of corneal ulcer and opacity. If left untreated, flectennular conjunctivitis can lead to serious complications, most notably corneal ulceration with subsequent opacity. This can result in permanent vision impairment. Early recognition and management are essential to prevent these outcomes and preserve ocular health. Treatment focuses on improving the patient's general health and hygiene, especially in children. A nutritious diet, rich in vitamins A and D, is recommended, and underlying causes, such as tuberculosis or tonsillitis, should be addressed. Locally, Topical corticosteroid eye drops or ointment are highly effective, and antibiotics are used if secondary infection is present. If the cornea is involved, 1% atropine ointment and dark glasses may be prescribed to relieve photophobia. Xerosis refers to a dry, lusterless condition of the conjunctiva, while xerophthalmia is a more severe form involving the cornea, often due to vitamin A deficiency. The conjunctiva and cornea are normally kept moist by a combination of lacrimal fluid, oily secretions from meibomian and Zeiss glands, and mucus from goblet cells. Disruption in any of these components can lead to dryness and increased risk of infection. The conjunctiva and cornea remain moist thanks to a delicate balance of secretions. Mucus from goblet cells forms the innermost layer, covered by lacrimal fluid and topped by an oily film from meibomian and Zeiss glands. This oily layer prevents excessive evaporation of tears. Blinking helps distribute these secretions evenly, ensuring the ocular surface stays hydrated and protected from environmental irritants. Xerosis can result from various factors. Exposure due to eyelid malposition, such as ectropion or proptosis, can lead to dryness. Deficiency of mucus, often from burns, trachoma, or vitamin A deficiency, destroys goblet cells. Tear deficiency, as seen in Sjogren's syndrome, also contributes. Recognizing these causes is vital for targeted treatment and prevention of complications. Xerophthalmia and keratomalacia are severe consequences of vitamin A deficiency, leading to atrophy and keratinization of the conjunctival and corneal epithelium. These conditions are most common in young, malnourished children, especially those from low socioeconomic backgrounds or with chronic illnesses. Early intervention is critical to prevent irreversible damage and vision loss. The earliest symptom of xerophthalmia is night blindness, where affected children struggle to see in dim light. Beetle's spots, triangular, raised, foamy, whitish patches appear on the conjunctiva, usually on the temporal side. The conjunctiva and cornea become dry and lusterless, and corneal sensation diminishes, increasing the risk of ulcers, perforation, and severe complications like adherent leukoma or anterior staphyloma. If left untreated, xerophthalmia can lead to serious complications such as corneal ulcer perforation, adherent leukoma, anterior staphyloma, conjunctivitis, and blepharitis due to secondary infection. These complications can cause permanent vision loss and significant morbidity, highlighting the importance of early recognition and intervention. Treatment involves addressing the underlying cause and restoring ocular moisture. Artificial tear drops should be used frequently in severe cases, and antibiotic ointment at bedtime helps prevent secondary infection. In some cases, tear preservation techniques like punctal plugs or cauterization are used to retain existing tears. Treating complications such as ulcers and conjunctivitis is also essential. Systemic treatment for xerophthalmia includes intramuscular injections of vitamin A, which can preserve the cornea if administered early. A diet rich in vitamin A, such as fish, liver, eggs, milk, fruits, and green vegetables, is crucial. Prophylactically, all children under 5 should receive oral vitamin A drops every 6 months to prevent xerophthalmia, especially in high-risk populations. Pinguecula is a small, raised, yellowish triangular patch resembling fat, commonly seen in elderly individuals exposed to sunlight, dust, and wind. It is usually located on the nasal side of the eye, away from the limbus, and consists of degenerated elastic tissue. Pinguecula does not cause symptoms and typically requires no treatment. Chemosis refers to the swelling or oedema of the bulbar conjunctiva, which becomes boggy and loses its transparency. This condition can result from acute inflammation, obstruction to circulation, or abnormal blood conditions such as anemia or nephritis. Recognizing chemosis is important for identifying underlying systemic or ocular diseases. Chemosis can be caused by acute inflammation, such as gonococcal conjunctivitis, panophthalmitis, or acute glaucoma. Obstruction to circulation from orbital tumors or abnormal blood conditions like anemia and nephritis can also lead to conjunctival oedema. Identifying and treating the underlying cause is essential for effective management. The primary approach to treating chemosis is to address the underlying cause, whether it is inflammation, circulatory obstruction, or a blood disorder. Supportive care may include lubricating eye drops and measures to reduce swelling. Early intervention can prevent complications and restore normal conjunctival appearance. The sclera is a tough, avascular, fibrous tissue that forms the white part of the eye. Because of its structure, it is relatively resistant to trauma and infection, and its inflammations are rare and usually chronic. When scleral disease does occur, it often presents as a slow, persistent process requiring careful evaluation and management. Episcleritis is a benign inflammation of the episcleral tissue, often seen in elderly female patients. It is usually an allergic reaction to endogenous proteins or toxins, such as those from tuberculosis or streptococcal infections. Episcleritis typically presents with pain, tenderness, and discomfort, but is generally self-limiting and non-destructive. Clinically, episcleritis presents as a hard, pinkish-red, lentil-sized nodule under the conjunctiva, typically 2 to 3 millimeters from the limbus. The nodule is fixed and tender, with freely movable conjunctiva over it. It never ulcerates and is eventually absorbed, sometimes leaving a slate-colored scar. The nodule consists of leukocytic infiltration and has a strong tendency to recur. Differentiating episcleritis from scleritis is important. Episcleritis typically affects older adults, is located away from the limbus, and presents with tenderness. Scleritis, on the other hand, is more severe, often bilateral, and associated with systemic diseases. Accurate diagnosis ensures appropriate management and prevents complications. Treatment of episcleritis includes frequent corticosteroid eye drops and ointment, subconjunctival decadrone injections, and hot compresses. Analgesics and anti-inflammatory medications help relieve pain. Addressing any underlying systemic cause is also important for complete recovery. Scleritis is a serious inflammatory process affecting the deep scleral tissue, often bilateral and more common in women. It is frequently associated with systemic diseases such as rheumatoid arthritis, tuberculosis, or viral infections. Scleritis can be very painful and may lead to significant ocular complications if not treated promptly. Scleritis is classified into anterior and posterior types. Anterior scleritis, seen in 95% of cases, includes diffuse, nodular, and necrotizing forms. Posterior scleritis is less common and affects the back of the eye. Necrotizing scleritis, also known as scleromalacia perforans, is particularly destructive and may follow eye surgery or trauma. Patients with scleritis experience severe pain radiating to the forehead and jaw, along with dark red or bluish patches on the sclera that are tender to touch. Multiple hard whitish nodules may be seen in the inflamed area. Necrotizing scleritis can cause thinning and destruction of the sclera, leading to serious complications such as uveitis and secondary glaucoma. Scleritis can lead to complications such as sclerosing keratitis, uveitis, secondary glaucoma, and staphyloma due to scleral thinning. Investigations should include tests to rule out systemic diseases and ocular ultrasonography if needed. Early and accurate diagnosis is crucial for preventing vision-threatening outcomes. Treatment of scleritis focuses on relieving pain and controlling inflammation. High-dose systemic corticosteroids, such as prednisolone, are the mainstay, with gradual tapering as inflammation subsides. Analgesics and anti-inflammatory drugs like indomethacin may be used. Surgical intervention is rarely needed, except in cases of scleromalacia perforans, where scleral grafting may be considered. Staphyloma refers to the outward bulging of the sclera, or cornea, resembling a grape, and is often accompanied by protrusion of the uveal tissue. This occurs when thinning of the sclera or cornea makes them unable to withstand normal intraocular pressure, leading to bulging. Staphyloma can result from various underlying eye diseases and injuries. There are several types of staphyloma, classified by their location. Anterior staphyloma involves the cornea and iris, usually following corneal ulceration. Intercalary staphyloma affects the sclera near the root of the iris, often seen in absolute glaucoma. Ciliary staphyloma occurs just behind the limbus over the ciliary body, while equatorial and posterior staphylomas involve the sclera and choroid near the vortex veins, or posterior pole, respectively. Posterior staphyloma is characterized by bulging of the sclera and choroid near the back of the eye, often seen in high myopia. It can be identified by ophthalmoscopy, which reveals chorioretinal degeneration and kinking of retinal vessels over the staphyloma. If the media is opaque, ultrasonography can aid in diagnosis. Unfortunately, there is no effective treatment for staphyloma. In cases of bleeding anterior staphyloma, evisceration may be performed, while enucleation is considered in cases of extreme disfigurement. Preventing the underlying causes, such as corneal ulcers and scleritis, is the best strategy for reducing the risk of staphyloma. In summary, disorders of the conjunctiva and sclera, such as pterygium, subconjunctival hemorrhage, flectennular conjunctivitis, xerosis, episcleritis, scleritis, and staphyloma, can significantly impact eye health. Early recognition, accurate diagnosis, and appropriate management are essential for preventing complications and preserving vision. Maintaining good general health, nutrition, and eye hygiene are important preventive measures. Thank you for joining us on this journey through eye surface disorders.